Diabetes is a chronic multi-system disease that is related to the abnormal production of insulin, impaired insulin utilization, or both. Close to 29 million people, or 9% of the U.S. population, have diabetes, and another 8 million have it but are unaware. Diabetes is the seventh leading cause of death in the U.S. Diabetes is a leading cause of adult blindness, end-stage renal disease, which is comparable to chronic renal failure stage 5, where these patients need dialysis, non-traumatic lower limb amputations, and it's a major contributing factor to heart disease and stroke. Part of what makes diabetes such a devastating disease is the long-term complications associated with it. Due to the effects of diabetes on the vascular system, it's a major risk factor for heart disease and stroke. Compared to non-diabetics, people with diabetes have a 2 to 4 times higher chance of having a stroke or developing heart disease. Diabetes escalates the process of plaque formation in our vasculature. Diabetes is linked as a singular or combination cause, and some of the factors include genetics, an autoimmune response. Environmental factors include obesity, various viruses, inactivity, and advanced age. Regardless of the factor, diabetes can lead to absent, insufficient, or poor utilization of insulin. Insulin is a hormone that is secreted by the beta cells in our pancreas. There's going to be a small continuous amount or basal rate of insulin that's pumped into our bloodstream to maintain normal glucose levels and prevent lipolysis, or the breakdown of fat. In addition, large amounts or bolus doses are released in response to food intake and rising glucose levels. Insulin is going to work to keep our glucose levels between 70 to 110. That's a normal glucose level in a patient without diabetes. After the first 1 to 2 hours after eating, insulin concentrations peak, and you're going to see a sharp decline as carbohydrate absorption from the GI tract decreases. Insulin promotes glucose transport from the bloodstream across the cell membrane to the cytoplasm of the cell. From here, cells are going to break down glucose to make energy and store excess glucose as glycogen in the liver and muscle cells. Insulin is also going to enhance the storage of fat into adipose tissue and increase protein synthesis. This slide is a depiction of the release of insulin in combination with a rise in blood sugar and the transport of glucose across the cell membrane into the cytoplasm. This picture offers another view of the relationship between glucose, insulin, and the cell receptor site. Insulin is going to bind to the receptors along the cell walls of muscle and liver cells. This is going to allow glucose to enter the cell, where it is either stored or used to make energy. So insulin is the key, the receptor site is the lock. Insulin is going to open this receptor site to let the glucose flow in. Counter-regulatory hormones are known as glucagon, epinephrine, growth hormone, and cortisol. These hormones oppose the effects of insulin. They're going to stimulate glucose production and the release of stored glucose. They also decrease movement of glucose into the cell. Their job is to help maintain and balance normal glucose levels. We'll typically see a rise in these hormones during a period of fasting, illness, or stress response. Again, they oppose the effects of insulin, but they also work with insulin to balance our glucose levels. Okay? So when we're in a state of fasting, starvation, they're going to help us to release and to utilize our stored glucose. According to the ADA, or American Diabetes Association, there are 4 different classes of diabetes. The most common are type 1 and type 2. Prediabetes places an individual at risk for developing type 2. Gestational diabetes places an individual also for developing type 2 later in life. Gestational diabetes, usually associated with large birth weight babies. You will talk about this more in your labor and delivery rotation. Other specific types might include cystic fibrosis, where you'll discuss this condition in your pediatric rotation. Type 1, which is formerly known as juvenile or insulin-dependent diabetes, accounts for only about 5 to 10% of all people with diabetes. Generally is going to affect people under the age of 40, but it can occur at any age. This is why it's no longer appropriate to call it juvenile onset. And then people who have type 2 diabetes or other forms of diabetes may also be candidates for insulin. So it's not appropriate to call type 1 insulin dependent anymore. Type 1 is thought to be an autoimmune disorder where the body's going to develop antibodies against insulin or the B cells that produce insulin. So it's quickly going to result in not enough insulin to survive or to be secreted. The autoantibodies to the B islet cells cause a reduction of 80 to 90% of normal functioning before hyperglycemia or increased blood sugar is seen and subsequent manifestations occur. There's going to be a genetic link that's triggered by a virus. So there's going to be a predisposition to type 1 diabetes is going to be related to something known as a human leukocyte antigen. So theoretically, when an individual with this antigen is exposed to a virus, the B cells of the pancreas are destroyed either directly or through this autoimmune process. The HLA or antigen types associated with an increased risk for type 1 include HLA-DR3 and HLA-DR4. Idiopathic, or meaning we don't know, is a form of type 1 that is strongly inherited and not related to autoimmunity. It's seen in a small population of people of Hispanic, African, or Asian ancestry. The last is latent autoimmune, which is a slow progressive autoimmune form of type 1, which is seen in older adults. And unfortunately, a lot of times, because it is such a gradual progress, it's mistaken for type 2. In type 1, the islet cell autoantibodies responsible for B cell destruction can be present for months to years before symptoms occur. Manifestations are going to develop when the pancreas can no longer produce insulin, and then there's going to be a rapid onset of complications such as ketoacidosis. And although ketoacidosis is something you'll talk about in 508 in subsequent semesters, in patients with type 1, where you have absolutely no insulin, the cells are starving, they're going to have to start breaking down the fats and proteins in mass quantities, and this is going to result in the production of ketones in an acidic environment, which is very dangerous and detrimental to the body. So type 1 is going to necessitate insulin, okay? And so a lot of times, because it takes this 3 to 12 months before insulin is completely obsolete, you may have what's known as a honeymoon phase. So some of these patients with type 1 will be started on very, very tiny doses of insulin, and they'll be very responsive to it. So this is known as the honeymoon phase, which will typically go away over time. Type 2 diabetes was formerly known as adult onset or non-insulin dependent, but we know that that's not the case because there are increasing prevalence in children developing diabetes type 2 secondary to obesity. And also, it's not appropriate to call it non-insulin because these patients most often will have insulin that they're taking. It's the most prevalent type. Somewhere between 90 to 95% of all diabetic patients have type 2. There are many risk factors, including obesity, advanced age, and family history. It's also genetic. And there's thought to be a greater prevalence in ethnic groups. The etiology is really not known, but the speculation is more about just environment, like lifestyle related to the cultures. In type 2 diabetes, the pancreas usually continues to produce some self-made insulin, and this term self-made is known as endogenous or inside. However, the body either does not produce enough insulin or does not use it effectively, or both. The presence of endogenous insulin is a major distinction between type 1 and type 2 diabetes. Type 1, there is none, whereas in type 2, there still is some. So with type 2, there's metabolic abnormalities that play a role in the development of type 2. It's also most likely a genetic link. Okay? It's going to lead to insulin resistance because insulin receptors are going to become unresponsive to the action of insulin and are insufficient in the number. And most insulin receptors are located on skeletal, fat, and liver cells. When insulin is not properly used, the entry of glucose into the cell is impeded, resulting in elevations in blood glucose or hyperglycemia. In the early stages of insulin resistance, the pancreas responds to high glucose by producing more insulin. So this is going to create a coexisting state of high glucose and high insulin. There's going to decrease in the ability of the pancreas to keep producing these high levels of insulin, and the B cells are going to become fatigued or compensated. And so there's going to be B cell mass going to be lost. There's also going to be a link to adverse effects of chronic elevations in sugar and high levels of free fatty acids. In addition to the insulin resistance and the beta cell exhaustion, the alpha cells of the pancreas, the ones that secrete glucagon, are also going to be increased, okay? So this is going to result in inappropriate glucose production and release from the liver. Instead of properly regulating the release of glucose in response to low blood glucose level, the liver is going to do so haphazardly that doesn't correspond to what the body needs. But however, this is not the primary factor in the development of type 2. It's insulin resistance and beta cell exhaustion, or decreased in the amount of production from the beta cells. But there's also going to be altered production of hormones and cytokines by adipose tissue. And these hormones and cytokines are going to be known as adipokines. And these adipokines are secreted by adipose tissue. They play a role in glucose and fat metabolism, and they contribute to the pathophysiology of type 2. They're thought to cause chronic inflammation, which is a main contributing factor to insulin resistance. So type 2 diabetes is a gradual onset. So patients may go years without having any detectable hyperglycemia because they're asymptomatic. They typically don't have symptoms. Many patients are diagnosed via a routine lab testing when they undergo treatment for other conditions. So the signs and symptoms of elevations in glucose are going to develop with patients with type 2 when somewhere between 50 to 80% of their B cells are no longer able to secrete insulin to keep up. So at the time of diagnosis, patients with type 2 have had their disease for somewhere between 6.5 to 7 years. So this slide is going to be just a depiction of the altered mechanisms in type 1 and type 2 diabetes. So kind of familiarize yourself with the difference between type 1 and type 2. So individuals diagnosed with prediabetes are at increased risk for the development of type 2 diabetes. Prediabetes is defined as impaired glucose tolerance, impaired fasting glucose, or both. It is an intermediate stage between normal glucose homeostasis and diabetes when the blood glucose levels are elevated, but not high enough to meet the diagnostic criteria for type 2 diabetes. A diagnosis of impaired glucose tolerance, or IGT, is made if a 2-hour oral glucose tolerance test values are somewhere between 140 and 199. Impaired fasting glucose is diagnosed when fasting glucose levels are 100 to 125. So again, this is going to be prediabetes where there's an intermediate stage between normal glucose homeostasis and type 2 diabetes. People with prediabetes usually don't have symptoms. However, there's still damage being done to their heart and blood vessels. It's important for these patients to undergo screening and to understand their risk factors for diabetes. Patients with diabetes or with prediabetes can take action to prevent or delay the development of type 2. We need to encourage those with prediabetes to have their glucose and A1C levels checked regularly and monitor for symptoms of diabetes. They need to maintain a healthy weight, exercise regularly, and make healthy food choices, having been found to reduce the risk of developing overt diabetes in patients with prediabetes. So diabetes is going to occur in some people because of another medical condition or due to the treatment of the medical condition. So some of these conditions can cause diabetes, a temporary condition from the injury or interference with B cell function. Some of these conditions might include Cushing's, increased thyroid, pancreatitis, cystic fibrosis, and the use of something known as parental nutrition, or TPN. Some common medications that you're going to see induce like a pseudo-diabetes is going to be steroids like prednisone, thiazide diuretics, dilantin, and clozapine. Okay, so the conditions are going to resolve when either the underlying condition or the medication is taken away. So often, like if these patients are on steroids and maybe they're also diabetic, these patients may need higher doses of medications or insulin to maintain their blood sugars because they're more elevated with being on these medications or having these conditions. Because the onset of type 1 diabetes is rapid, a lot of their initial manifestations are also acute. The classic symptoms are going to be polyuria, polydipsia, and polyphagia. The osmotic effect of glucose produces the manifestations of polydipsia, which is excessive thirst, and polyuria, which is excessive urination. Polyphagia is a consequence of cellular malnourishment when insulin deficiency prevents utilization of glucose for energy. Weight loss may occur because the body cannot get glucose and turns to other energy sources such as fat and protein. Weakness and fatigue are going to result from the body cells lack needed energy from the glucose. The clinical manifestations of type 2 diabetes are often nonspecific, although it is possible that an individual with type 2 diabetes will experience some of the same symptoms associated with type 1, including polyuria, polydipsia, and polyphagia. Some of the more common manifestations associated with type 2 are going to be fatigue, infections, vaginal or candidal infections, prolonged wound healing, and visual changes. And these are most commonly related to the fact that patients didn't know they had type 2 diabetes, and it may have lingered longer without treatment. The diagnosis of diabetes mellitus is made using one of 4 methods. These methods and their criteria are used for diagnosis. So a hemoglobin A1C of 6.5 or higher, a fasting glucose level of 126 or higher. Fasting is defined as no caloric intake for at least 8 hours. A 2-hour plasma glucose level test greater than 200. And then in patients with symptoms of hyperglycemia, and a random glucose level of 200. In patients presents with a hyperglycemic crisis or clear symptoms of hyperglycemia, and there's a random glucose level of 200, repeat testing is not indicated. We are certain that this person has diabetes. However, if diagnostic testing and criteria from 1, 2, and 3, hemoglobin A1C, fasting plasma glucose, or 2-hour plasma glucose, these patients need to have a repeat test done to confirm diagnosis. And preferably, it's going to be with that same test that they had initially. So for example, if a random blood glucose test showed an elevated glucose level, that same test should be used when the person is retested. The term A1C measures the amount of glycosated hemoglobin as a percentage of total hemoglobin. So hemoglobin A1C of 6.5 means that 6.5% of the total hemoglobin has glucose attached to it. The amount of hemoglobin that is glycosated depends on the blood glucose level. When blood glucose levels are elevated over time, the amount of glucose attached to hemoglobin molecule increases. This glucose remains attached to the red blood cell for the life of the cell, which is approximately 120 days. Therefore, A1C provides a measurement of blood glucose levels over the previous 2 to 3 months, with increases in the A1C reflecting elevated glucose levels. The A1C has an advantage over fasting glucose test because they have greater convenience and they don't have to fast for them. There are some diseases that are going to offset the A1C level, and that would be if somebody was anemic, so it wouldn't be as reliable. We need to teach patients with diabetes and prediabetes to have their A1C monitored regularly. The American Diabetes Association identifies the goal for patients with diabetes to have an A1C less than 7%. The American College of Endocrinology recommends an A1C of less than 6.5. And since your textbook is based on a lot of the recommendations from the American Diabetes Association, for testing purposes for me, I'm going to ask that you know that it needs to be less than 7. When the A1C level is maintained at near normal levels, there is a greater reduced risk for the development of vascular complications. The goal of diabetes management are to reduce symptoms, promote well-being, prevent acute complications related to hyper or hypoglycemia, which means increased or decreased blood glucose levels, and prevent a delay the onset and progression of long-term complications. These goals are most likely to be met when the patient is able to maintain blood glucose levels as near to normal as possible. Diabetes is a chronic disease that requires daily decisions about food intake, blood glucose monitoring, medication, and exercise. Patient teaching, which enables the patient to become the most active participant in his or her own care, is essential for a successful treatment plan. Nutritional therapy, drug therapy, exercise, and self-monitoring of blood glucose are the tools used in the management of diabetes. For some people with type 2 diabetes, a healthy eating plan, regular physical activity, and maintenance of healthy body weight are sufficient to attain an optimal level of glucose levels. However, for the majority, drug therapy is necessary because diabetes is a progressive disease. The major types of glucose-lowering agents used in the treatment of diabetes are insulin, oral agents, and non-insulin injectable agents. All individuals with type 1 diabetes require insulin.